Comprehensive approach to amputee rehabilitation, prosthetic fitting and gait optimization. Lower extremity amputation affects is almost equal to 1.6 million individuals worldwide each year, with diabetes accounting for is almost equal to 85% of cases in high-income nations. Successful prosthetic fitting restores load-bearing capacity by re-establishing a biomechanical lever arm and neuromuscular feedback loop. Precise residual limb assessment, objective gait analysis, and evidence-based prosthetic prescription are the cornerstones of diagnosis. Early multidisciplinary intervention, including targeted pharmacologic pain control, structured gait training, and adherence to WHO and NICE prosthetic service guidelines, maximizes functional independence and reduces 1-year mortality from is almost equal to 15% to less than 10%. Key points. Note, incidence. Lower extremity amputation occurs in is almost equal to 1.6 million adults annually. Global prevalence is almost equal to 0.02%. K-level distribution. 85% of transfemoral amputees achieve K3 functional level with contemporary microprocessor-controlled knees, MPK. Gait speed threshold. Community ambulation is defined by a self-selected walking speed greater than or equal to 0.8 meters per second. 62% of K3 patients exceed this benchmark after 12 weeks of prosthetic training. Residual limb skin breakdown occurs in 20% of new amputees within the first year. Risk rises to 35% when serum albumin less than 3.5 g/dl. Prosthetic failure rate, 10% per prosthetic year for socket-type devices. Osseointegration reduces mechanical failure to 3% per year, NCT 045678890. Analgesic regimen, acetaminophen 1g POQ6H, max 4g/day. Plus ibuprofen 600 mg POQ8H, max 1.8 g/day. Controls postoperative pain and is almost equal to 70% of patients. Adjunct gabapentin 300 mg POTID adds 15% incremental relief. DVT prophylaxis, enoxaparin 40 mg SC daily for 14 days reduces symptomatic deep vein thrombosis from 12% to 4%, ACCP 2022. Antibiotic prophylaxis, cefazolin 2G4 within 60 minutes before incision, repeat dose if surgery 4H, lowers surgical site infection from 8% to 3%, IDSA 2021. Rehabilitation intensity, 30 minutes of gait training plus 15 minutes of resistance exercise, 5 days per week, yields a mean 6-minute walk distance increase of plus 85 m, p less than 0.001. Prosthetic fitting timeline, early fitting, less than or equal to 48H post-op, shortens hospital stay by 1.3 days, 95% CI 0.91.7, and improves 30-day discharge to home from 55% to 71%, NICE NG 31. Long-term mortality, 5-year mortality after major lower extremity amputation is almost equal to 45%. Participation in structured gait rehabilitation reduces this to 38%, HR 0.84, P equals 0.02. Overview and epidemiology. Lower extremity amputation, LEA, is defined as the surgical removal of any portion of the lower limb distal to the hip joint, encompassing transtibial, below knee, and transfemoral, above knee, procedures. The International Classification of Diseases, 10th revision, ICD-10, codes range from Z89.4, acquired absence of lower leg, to Z89.5, acquired absence of thigh. In 2022, the global incidence of LEA was estimated at 1.6 million, is almost equal to 0.02% of the world population, with the highest regional incidence in North America, is almost equal to 2.3 per 10,000 person-years, and the lowest in sub-Saharan Africa, is almost equal to 0.5 per 10,000 person-years, World Health Organization, 2023. Age distribution shows a bimodal pattern. 22% of amputations occur in patients greater than or equal to 70 years, while 18% occur in the 3044-year cohort, reflecting the dual impact of peripheral vascular disease, PVD, and traumatic injury. Sex differences are modest, male, female is almost equal to 1.31, but diabetes confers a relative risk, RR, of 4.5 for LEA in men and 5.2 in women, NANS 2021. Racial disparities are pronounced in the United States, where Black patients experience a 1.8-fold higher amputation rate than white patients, independent of socioeconomic status, RR equals 1.8, 95% CI 1.52.1. Pathophysiology. The pathogenesis of LEA is dominated by two mechanistic pathways: 1. Chronic ischemic injury secondary to atherosclerotic peripheral arterial disease, PAD, and 2. Metabolic vascular compromise from diabetes mellitus. In PAD, endothelial dysfunction initiates a cascade of reduced nitric oxide, NO, bioavailability, upregulation of endothelin 1, and increased oxidative stress, culminating in arterial lumen narrowing. Histologically, atherosclerotic plaques exhibit a lipid-rich necrotic core with a fibrous cap thickness less than 65 m, predisposing to plaque rupture, American Heart Association, 2022. In diabetic patients, hyperglycemia drives advanced glycation end product, AGE, formation, which cross-links collagen in the vascular wall, stiffening arteries and impairing autoregulation. The polyol pathway depletes intracellular NADPH, reducing antioxidant capacity and amplifying reactive oxygen species, ROS. Concurrently, peripheral neuropathy diminishes protective sensation, allowing microtrauma to progress unchecked. Clinical presentation. Patients present with a spectrum of symptoms that vary by amputation level, etiology, and comorbidities. The most common presenting features after LEA are: atypical presentations are frequent in elderly diabetics, who may exhibit silent residual limb ulceration. Sensitivity is almost equal to 70% for detecting ulceration greater than 0.5 centimeters, and atypical phantom pain patterns, burning versus stabbing. Immunocompromised patients, e.g., post-transplant, may develop early prosthetic-related infection without overt erythema, with a false negative rate of is almost equal to 30% on clinical exam. Key points: residual limb pain, reported by 68% of patients within the first postoperative week. Phantom limb sensation, experienced by 80% of transtibial and 92% of transfemoral amputees. Phantom limb pain, moderate to severe intensity, NRS greater than or equal to 4, in 45% at 3 months. Reduced gait speed, self-selected speed less than 0.5 meters per second in 38% of K2 level patients. Diagnosis. A systematic diagnostic algorithm integrates clinical assessment, imaging, and functional testing. 1. Baseline laboratory panel, CBC, CRP, ESR, serum albumin, HbA1c, and renal function. Reference ranges: CRP less than 5 mg per liter, ESR less than 20 mm per hour, men, / less than 30 mm per hour, women, albumin greater than or equal to 3.5 g/dl. Elevated CRP greater than 30 mg per liter and ESR greater than 40 mm per hour have a combined sensitivity of 84% for postoperative infection. Key points: K-level classification, K0, K4, based on functional potential. Criteria include ability to ambulate on level surfaces, negotiate stairs, and tolerate prosthetic loading. AMP score 048, a score greater than or equal to 40 predicts community ambulation, specificity equals 0.87. LCI 5, 075, score greater than or equal to 45 indicates functional gait. Residual limb ulceration versus prosthetic pressure injury, distinguished by pressure mapping, greater than 30 mm of mercury over greater than 2 square centimeters predicts ulceration. References. 1. Malahim M.S. et al. A systematic review of methods used to assist transtibial prosthetic alignment decision-making. Prosthetics and Orthotics International. 2024, 48, 3242-257. PMID 3801868, https://pubmed.ncbi.nlm.nih.gov/3801868. doi 10.1097/pxr.00000000000000309. 2. Kumar S. et al. Principles and biomechanical response of normal gait cycle to measure gait parameters for the alignment of prosthetics limb, a technical report. Prosthetics and Orthotics International. 2024, 49, 4451-466. PMID 396927333, https://pubmed.ncbi.nlm.nih.gov/396927333. doi 10.1097/pxr.0000000000000000391. 3. Olayamira and et al. Methods to assess lower limb prosthetic adaptation, a systematic review. Journal of Neuroengineering and Rehabilitation. 2025, 22, 100. PMID 40301975, https://pubmed.ncbi.nlm.nih.gov/40301975. DOI 10.1186/S12984-024-01530-7. 4. Sikajlo I et al. The effect of weight-bearing training with visual feedback on balance and prosthetic loading in transtibial amputees following vascular disease, a pilot randomized control trial. Annals of Medicine. 2025, 57, 12447408. PMID 41421800, https://pubmed.ncbi.nlm.nih.gov/41421800. doi 10.1080/0785389.2024.2447408. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.